Good morning, everybody, or good evening, depending on your country. I would like to thank World Dental Association for this kind invitation. Actually, we will talk today about the bone graft technique, and especially one bone graft technique that we developed in 2010, which is called the MPM, and now it is called the sticky bone. My name is Mohammed Almoheb. I'm a dental surgeon living in Paris and running my private clinic. Uh, I'm lecturing in several congresses and meetings international. I'm lecturing also in University of Bordeaux and University of Marconi in Italy. I am MSc holder and postgraduate from NYU. My practice is focused on implant and periodontology. I'm scientific advisor of trade, Open Dental Community, and IGOR, our dental association in Paris. So today I would like to start my presentation by talking about this case. For example, if you have tomorrow in your clinic, hope tomorrow or Monday we will open our clinic anyway here in France. I don't know you when we'll open. Hope you will open as soon as possible. So if you got this case in your clinic, as my case, she was wearing a removable, and she was upset with this removable. She wanted to get rid of that. As we see, we have a resorption around this lateral. We have a vertical loss, little vertical loss. We have remaining roots, and said that we have to take these out. What will be the solution to place implant in this region? If we go to make a CT scan, we can see that we don't have any width here, and placing an implant in the right position needs for sure bone augmentation, bone graft, as vertical as horizontal, and a little bit vertical augmentation, but for sure we need to make a lot of horizontal augmentation. As we see, this is the lateral with all the bone loss that we can have on this lateral incisor, and this problem that there's a combination of problems in this case. So here we can see that we have almost only 2 millimeter of thickness and the loss of this bone around the lateral. So what will be the solution for this patient? Can we make a splitting to increase the width of this part here? Actually, splitting need more than 2 millimeters, and as we have resorption here, so this splitting will not work. So we will forget about it. We will talk about bone grafts. It will be maybe bone blocks. It will be Khoury technique or JBR. Can we make vertical and horizontal bone augmentation with JBR? We are going to discuss that. But who talks about JBR? Talks about bone grafts or bone substitutes and membranes. When we talk about the bone blocks here, the bone blocks, the old style bone blocks, when we took blocks cortical and sponges bone blocks together and replace them, we got a lot of failures. And anyway, I think it didn't work in my hand. Maybe it works in other hands. And the problem here is that we always get this cortical bone left. A few years later, this cortical bone will get resolved, and because it's a dead bone, and we will get our implant exposed to the soft tissue. So now we have this Khoury technique, these shells. When we take only a small bone block here and split it on two parts, to make a small shell to hold the particles that you are going to do. But because in fact The bone graft is the particles and it's not the blood. So what will give us the bone is the particles. The block of the shell in Hori technique, it's only a way to hold these blocks, these particles together, to stabilize them, to allows us to pack them. It's to be carpenter, you need to be carpenter, you need to take this block out, you need to harvest it, to screw it, and to pack all these particles between. It is time consuming. You need to shape these blocks. You will open another surgical site. They will increase the morbidity of the patient, and you will lose time. So, what are the bone graft and the bone substitute that we can use? Let us make a summary of these quickly. The bone graft, we have the allograft, which is the gold standard, which is the osteoinduction one, and it's osteoconduction. It is not really easy to take out. There is a lot of morbidity, and we are limited in the quantity. The allograft, it may be osteoconductive. Some articles are talking about this osteoinductive power of allograft. It is osteoconductive. It is easy to take. Actually, it depends on the countries. Here in France, not easy to have it. There's no morbidity, and the quantity is not limited. The Xeno and the alloplast are only osteoconductive. It's easy, and there is no morbidity. We can take it. We have an limited quantity. Let's talk about it. I will not go very over a lot on details, but let's talk about it a little bit. The autograft is the gold standard because of its osteocompatibility, and there is no risk of cross infections. What is important for me in this slide is that the harvesting procedures may affect the growth factors. Based on Myron studies, he demonstrated that the best way to get these growth factors in the on the autograft is by using a scraper. The scraper is the best way to get these growth factors that are imprisoned in the extracellular matrix between cells in the cortical bone, because the cortical bone does not contain a lot of cells, but it contains some growth factors, and scraping is the best way to get these growth factors out. So just keep this in mind, that the scraper is the best way to get these bone graft. This is why, anyway, in the shell of Hori technique, when we cut these shells, we start scraping to get get maximum of bone particles. We scrape a cortical bone. The allograft, there's two parts of allograft. There is the FDBA and the DFDBA. The FDBA is the one non-mineralized, demineralized, and the DFDBA is the mineralized one. So the mineralized one is more visible in radio, so you can get better control, radiographic control after your surgery. It maintains better the space because it will not resorb fastly, so there's no shrinkage of the graft because the DFDBA will resorb fastly. And it may be the FDBA, it is osteoconductive purely. The DFDBA, I really say that, it may be osteoconductive because of the osteoconductive, but it depends on the harvesting way and on the treatment that we can do. So the FDBA, as I said, the produce malformation is really varies. And if we talk about the DFDBA that may be inductive, it also may induce inflammatory reaction. The one that is not inductive, the purely conductive, there is no inflammatory reaction if the bone is treated correctly. The xenograft, the xenograft is the one that comes from animal. the one that is most widely studied and the most used one is the BIOS. What is interesting in the xenograft, it is interesting, and at the same time, it's not. This is a non-resorbable material. This is what is interesting and what is not interesting in the same time. Why it is resorbable? Not, it is interesting because it maintains the volume. So once we make our bone graft, we increase the graft, we increase the volume either in height or in vertical augmentation. If we mix it, our bone graft, that our bone substitute, if we mix with this BIOS, few years later, when we obtain this volume, a few years later, this volume will be maintained because of the non-resorbable characteristics of the BIOS or of the xenograft. While it's not interesting at the same time, because if it is in contact of implant, directly in contact with implant, we may get like reducing the resistance of the bone concerning the periimplantitis, and we are reducing the big bone implant contact. So it is interesting to use this bone to maintain the volume, but it's less interesting. There's an inconvenience. Actually, there is no product that is 100% perfect. The alloplast, as we know, the alloplast is the synthetic one. It's free of biological sources. It is free of cultural and religious beliefs. There's no cross infections, and the quantity that we can get is not limited. There is an interesting thing in this. It is the calcium that contains uh, uh, this alloplast, which may enhance the proliferation of osteoblast. I'm not telling about the induction, so it's not inducing the formation of osteoblast, but it is enhancing the proliferation of osteoblast. But there is a new thing which is very very interesting. Myron made a study about a new material, uh, synthetic material, which is osteoinductive. A synthetic material osteoinductive. Compared it to the allograft, to Xeno, and to FTDA. He put these materials in the muscles of animals, and he saw that we start having bone formation in these muscles. So these are a revolution materials that we're looking forward to use it. Still, at the moment, I cannot find them in the market, but they are talking about osteoinductive synthetic materials, which is really a revolution. So let us talk about the GBR a little bit. The GBR, can we make vertical and horizontal augmentation using GBR? Yes, we can make it. There is out of studies talking about 97% of success in vertical augmentation and in horizontal augmentation. The first one to talk about the vertical and horizontal augmentation using the GBR is Simeon. Simon is the godfather of the GBR, let's say. So the GBR, we use particulate bone. We do not use bone blocks, and this is very interesting. Why? Because Albertson in 1980 he demonstrated that the growth of blood vessels in the particles trabecular bone is 0.5 millimeters per day, while in cortical bone is 0.05 millimeters per day. So if we use these particles, the growth of blood vessels inside is faster than the growth inside the bone blocks. Another interesting studies by Simeon also, as I said, he's the godfather of the GPR. He showed that the GPR technique demonstrated vertical augmentation for 4 millimeters vertical augmentation is predictable. He he talked about the bone that is produced by GBR is like native and not generated bone. So this go in 2010 showed 5.2 millimeters of vertical augmentation, but it was only limited on 25 cases. We've then on 214 showed 5.45 millimeters of vertical augmentation, but also it was limited only on 20 cases. So these cases are very limited, so we cannot really rely on these. But what is interesting is that the Elnaif who made a systematic review with meta-analysis. So he gathered all these studies and he made his analysis, and the result was that augmentation up to 4 millimeters of vertical edge in DBR is predictable. Another interesting study is a split mouth done by Fontana. He from a side he put PTFE with allogenic bone, and from the other side he put PTFE with autogenic bone. This is very interesting. So from a side he used allogenic bone, from the other side he used autogenic bone. And what he demonstrated is that from the autogenous bone we get 4.1 millimeters of augmentation, vertical augmentation, and from the FDBA or the DFDBA we get 4.6 millimeters of vertical augmentation. And they are having the same histological characteristics. This is a very, very interesting study. So after reading this study, we can say, can we replace our autogenous graft by the FDBA or by the DFDBA? This make the surgery less complicated. This make the surgery consuming less time, and we are getting almost the same results. So why now making another surgical site, increasing the morbidity of the patient, while we can use the FDBA and having these same results? So as I said, who talks about GPR, talks about bone graft, and talks about membranes. So if we take about the membranes, we have two types of membranes: the non-resorbable one and the resorbable one. The non-resorbable membranes, they have the main disadvantage of these membranes is that you need to make a second surgery to take these membranes out. The PTFE, there are two membranes of these. They are the PTFE, the EPTFE, and the DPTFE. The EPTFE or the DPTFE, they can be reinforced with titanium or not. Actually, it depends on what we want to do. If I want to go for vertical augmentation, I will always use the titanium reinforced one. The problem also of this membranes, the PTFE, these are the goal for me. This is the best membrane that we can use. The ePTFE is the oldest one, but the problem with the PTFE membranes, as reported by Simeon, is that there is 12 to 17% of exposure of the membrane. And if you get an exposure of an ePTFE membrane, as Fotex demonstrated, there is a high risk of infections, and this membrane should be taken out. While if you use the DPTFE, the dense PTFE, you can keep it out. Even you can keep it in place, even if there is an exposure. There is no infection risk. The titanium mesh, I don't consider this mesh as a membrane. I call them titanium mess because it is really a mess when you want to take it out, and it destroy your graft, destroy your soft tissue. Anyway, at least in my hands, maybe it works in the hands of other, but I stopped working with these since a long time. The resorbable membranes. The resorbable membranes, we have three kinds of resorbable membranes. The synthetic resorbable membrane, the first generation of synthetic membrane, the polyglytic acid membrane, it may induce an inflammatory reaction, as demonstrated by Swartz in 2008. The cross-link cross-linked collagen membrane, it is a synthetic one. We cross-link it to increase the resorption rate, so it will last for more time. The problem of this cross-linked membrane is that the poor irrigation, it's allowing poor irrigation, as Schwartz demonstrated in 2005. And if it is exposed, there is 48% of loss of your graft, as demonstrated by Park in 2008. So the last one is the native collagen membrane. The problem of the native collagen membrane is the resorption is fast, but it may allow an early vascularization. And we have the PGA membrane now, the synthetic PGA, as demonstrated by Urban in 2011. He compared the PGA membrane to the native membrane, and he saw that we obtained the same results, the same vertical augmentation of our same horizontal augmentation, but the native collagen membrane is more easy to use than the PGA. So let us demonstrate a little bit, and let us see this case. This patient came to me. She was having four implants, and we can see here one of the implants with a pink ceramic, and she was not happy with that. She wanted to change this implant. The solution for us was to take out the implants to make a vertical augmentation. It's almost about 7 millimeters. What was our choice for this patient? We chose to make a vertical augmentation using the PTFE membranes, the DPTFE membranes, the dense one reinforced with titanium, and using our preparation of bone, the MPM, which is now, as I said, it is a sticky bone. It's called a sticky bone now. We developed this MPM in 2010 by me and my teacher in Toulouse University, and then a lot of study was conducted on it. Then in 2011, we got the sticky bone, and in 2014 we got the IPRF, which all these products are the same, almost the same. So here we started like this for this patient, and this is the bone that we obtained by making our bone graft. This is the height, and this is the end result. You can see that we have a little bit not the same height, left and right side. We get a little bit of shrinkage here. This is because we get an exposure of the membrane at this side. Another case, we have a vertical and horizontal bone loss, which is more than 7 millimeters. You see here the horizontal bone, its thickness, it's only 2 millimeters of the figure. It's impossible to place an implant in the right position here. So a vertical and the horizontal augmentation should be done for this patient. You can see the loss of this bone. This patient runs a lot of surgical procedures to place implants and to make bone grafts, and some of them failed. Some of them, the implants were taken out because they was in a bad position and cannot restore it. So he came to our clinic in this situation, and we chose to make for him a vertical augmentation using the DPTFE membrane, as you see in this picture, reinforced by titanium mesh, titanium mesh reinforced by titanium. And this is our MPM bone graft that we prepared before. We are shaping this membrane. You see this titanium reinforced, this PTFE reinforced titanium, and the result for the patient 6 months later, you can see the thickness that we obtained for this patient. It's more than 6 to 5 millimeters at least, and then here we can place our implants easily and restore the aesthetic and the function for this patient. To get bone regeneration, actually, we need to have scaffolding, the space maintaining, environment, stability. The stability is very, very important. This is why we use these PTFE membrane reinforced with titanium. And in addition, we add our sticky bone or our MPM, and we need cells that will generate bone. We need the growth factors. We can talk about the growth factors in details, but I didn't choose to talk about this. This is not about our topic today. We can see if this is myth or reality, and then we get the closure. So it's only I want to talk a little bit about these growth factors. A lot of companies will tell you, please buy my centrifuge because it's making more growth factor than other. It's better growth factors. I advise you not to believe in these because this is a purely commercial thing. So you can obtain your PRF, if you'd like to work with it, your sticky bone with any centrifuge. So the MPM is a product of mixture between bone substitute and bone graft or bone graft particles with autologous fibrin network. As you see, I'm not talking about growth factors. I'm talking only about fibrin network because this fibrin network will hold all the particles together, all the particles of my bone blocks. As you can see, here it's one particle of BioOS. It's held to the whole MPM, is attached to the whole MPM by these fibrin network that will stabilize this particle. This particle will not move. We are not going to lose this particles once we put it. We can shape it. We can give it the shape as we want. So here you can see how we can prepare this MPM. We draw blood for the patient. We put it in a centrifuge. We use empty plastic tubes, no anticoagulant inside, no blood activator. Here for the workshop purpose we are using animal thrombin in the patient mouth. We take thrombin from the patient, so we don't do thrombin from the animal, but it's only for the workshop purpose. We add bios here, and we add some saline, water saline. Then after the centrifuge finished, we take out this. We will get the plasma, which is liquid, not in gel as the PRF. It's liquid. We inject it on the cup that contains the bone, and another cup that is empty. The cup containing the bone, we start mix it. That contains the bone and the thrombin and the saline. Here, the thrombin will activate the fibrinogen that is found in the blood and transfer it into fibrin. And this fibrin will form these MPM. This fibrin network will hold all the bone block, all the bones together. Then we add the liquid to the other cup in order to have some membrane. This membrane, I'm not using it anymore. Only maybe it enhances the soft tissue healing, but for sure it's not having any effect on the bone. So as you see, we can shape this MPM, this bone, once it is produced, and this is our membrane that in the past we cover always the bone block with it. Excuse me, bone particles with it. Great. So let's go further. Here's a little difference between the MPM and the PRF, because in the past we used to mix this PRF. We cut it in small pieces and we mix it with bone particles, with bone graft, and we use it to enhance. We thought that it can be used for that. As you can see here, you see the particles of bone attached to the whole MPM by the fiber network, which is stable. At the left side, at the right side, you can see the MPM, the bone grafts, bone particles that are not really attached to the old PRF in this procedure. So there is no stability here. And as we said, the stability is mandatory to have your success on your bone graft. I published this study in 2017 about comparing the PRF mixed with bone with MPM. In the left side and right side of the patient, we extract tooth. On the left side, we put MPM, and the left side, we put bone mixed with PRF. 14 days later, we harvest some samples to send it to biopsy to histology, and the MPM side we start having woven bone. So we are having osteoblast and osteoclast activity. In the PRF mixed with bone side, we are not having. We are having only granular tissue. There's no evidence for bone formation, but we have a lot of osteoclast. That doesn't mean that we're not going to get bone. We are going to get bone, but the MPM side is faster. Some clinical examples about what we how can we handle this situation. This is a patient. I place an implant for him, and I wanted to correct the horizontal depression for the aesthetic. I put my MPM, I put my membrane, I suture my membrane with periosteum apically. As we know, the periosteum is elastic, so it stabilizes my membrane. And this is the result 2 months later when I make my re-entry to put my healing cap and then taking my impression. You can see it is completely corrected. In this case, I love it so much. This patient came to me, and the doctors that sent it to me, they don't know what they can do or how I can handle the situation. There's no cortical bone in the lingual part in the left and in the right. She is willing to get implants procedures. So I was obliged to place my implant to make my bone grafts using the MPM technique. And here you can see at 6 months later how the cortical bone was reconstructed completely in the left side and in the right side. And this is 3 years later. You can see the bone is stable and it's really corticalized in the right side and in the left side, only by using this MPM. A patient came to me, has a knife edge from on the mandibular, and he wanted to place implants. I made my cone beam, my CBCT. The sensor was broken, so I cannot see the mental nerve. So I told the patient I will not place the implant. I will make only my bone grafts. I will place the implant 6 months later. So he said, okay. We placed our implant. This is the cut at 7 millimeters. I don't only place implant. I only placed my bone graft and put my membrane and sutures. So here is a 7 millimeters the cut. You can see the knife edge of the crest, and this is the result: 7 millimeters 6 months later. This is a case that I published also as a case report. This patient, we placed our implant, and there is a little small defect. We put our MPM and we put our membrane. Then we closed suture. This is 1 week later. This is 2 months later when the patient came to me and I start opening. I cannot find my implant. All the implant is covered with bone. I start looking at the implant by the current because at 2 months the bone is not very, very hard. It's a little bit soft. So I start curetting and I find my implant. And this is the soft tissue. Let us see at 6 months later the bone that he obtained on the buccal side, and this is at 1 year later all the bone that he obtained on the buccal side. So how can we manage? Sometimes we do not use the MPM because the only time that I do not use an MPM is that because I don't have soft tissue. I don't have tubes in my clinic. I'm running out of tubes. So this patient came to me with this teeth that is black, is dark, and she wanted to get rid of it. So we make an extraction immediate implantation of this patient. In this case, I didn't use MPA because, as I told you, I was running out of tubes. But I placed my implant, and luckily I had to place the implant a little bit luckily always when you make an extraction mid implantation. And I start filling the implant, the bone by the gap on the by the fenestration. As you can see, the bone is coming up. Then I will put my membrane. So once the socket is filled with the implant and the bone graft, in order to stabilize, it is stable here in this case because it is inside the socket. I will not lose, but I am putting my membrane in order to get a good quality of bone, in order not that to have an invagination of soft tissue and of fibroblasts inside my bone graft that will damage my bone graft, and especially in the superficial layer, that it will damage my bone graft. So this is why I'm placing my membrane. This is a PGA membrane, a synthetic one, resorbable one. The tags, we will not take it out, we keep it. So this is how we place our membrane, and we fix it. We do not need to take out these tags. So here is the final result for this patient. I want to talk to you before I finish my lecture and before I go back once again to the case that we started with. I want to talk to you about the screw design, because I used the screw design in my case and the case that we are going to talk about, that we start a lecture with it. This is a screw that I patented, and it's developed and now and produced by Root Implants, but it's patented by me. Actually, when we place our implant and we make a cover screw, there is no space between the implant platform and the screw. The screw is touching the implant, and as we know, as we said, in order to get bone, we have to have space maintaining. So we close the implant. The implant is touching we close the implant. The implant platform is touching the screw platform. There is no space between them, and there is no bone. Impossible that the bone grow on the top of the implant. So why we decided to get bone on the top of the implant? Actually, when we know that the soft tissue is protecting the bone always underneath, and when the teeth is breaching this soft tissue, is getting out. So the soft tissue is making a link and attachment around the teeth neck, in order to protect always the bone that is under the teeth. And this attachment is made by fiber, by ligaments that are perpendicular to the surface of the teeth. While if you talk about implant, these ligaments are not attached to the teeth, not attached to the implant surface, they attach to the bone, and it's parallel to the implant surface. So this parallel to the implant surface make that this region is having not a good defense against aggression. This is a weak point against aggression, and this is why the periodontal starts here, and this is why bone loss starts here. So in order to get more vascularization, because the vascularization of soft tissue around the teeth is coming from the periosteum, from the connective tissue, and also from the ligaments. While in case of implants, this irrigation is coming only from periosteum and from connective tissue. As we cannot increase the irrigation from the connective tissue, but we can increase the irrigation coming from the implant by increasing this from the periosteum, excuse me, by increasing this periosteum surface. So how we increase this periosteum surface? By increasing the bone on the top of the implant. If we want to increase the bone on the top of the implant, so we are going to use a screw that maintains the space between the implant platform and the screw platform. This space maintaining will allow the bone to grow on the top of the implant. It will act like a tenting screw, but it has a specific dimensions. That these dimensions are only 1 millimeter height, and it's having the same width of the implant. So this 1 millimeter height will keep the bone. Will this oblige us to place our implant 1 millimeter subcrestally, and we put our cover screw. When we put our cover screw, the cover screw is touching the bone around the implant and stopping the migration of these soft tissue. As we know, the body would do not love or hate the empty spaces, so he wants to fill the spaces by something. If we keep the choice for the body, either fill it with bone or fill it with soft tissue, he would choose to fill it with soft tissue because the soft tissue will migrate faster than the bone cells, much faster. So these soft tissue will fill the space on the top of the implant. So if we keep this space maintained and we keep this soft tissue far, not allowing them to migrate, but they will not have a choice. And the only choice that they have is to fill the space by bone cells. So this is how we can obtain bone on the top of the implant, 1 millimeter. And by growing it, by giving the bone on the top of the implant, we can get this increasing and reinforcing the longevity of the implant. Let us see, for example, this case. I placed my implant 1 millimeter on the bone. I put my screw root GF0, I called it. You see the space between the implant and the screw, and I cover this with the space covered with bone particles. And 2 months later, I could take out my screw. We can see the bone growing on the top of the implant. So how we place this implant, how we place the screw, we place the implant 1 millimeter on the bone, as you can see on the top on the left. And then once we put the screw, the screw is touching the bone and not allowing this soft tissue to grow on the implant top. So back to our case, the first case that we see. I tried to place my implant here. What I'm playing with is the nasal membrane. I was elevating it because I wanted to take this spin, nasal spin, to use it as for the graft, to mix it with the graft materials. We placed our implant. I made my extraction, I made the implantation, and as you see, the implant is almost outside the bone. I put my GF0 screws on these implants because I wanted that the bone grow on the top of the implant. Here I'm using a PGA membrane, synthetic membrane. I'm not using a PTFE reinforced with titanium. Why? Because I'm not going to make a vertical augmentation. It's only horizontal, so no need to use uh, these membranes. Here I use my MPM bone graft, and I close. Let us see the final result. This is the result on all the bone that we obtained at 6 months later. Here's the healing, and here is the end result, final result. And I hope you enjoyed, and thank you for your attention. Hello. Is there any question?